Did you know that as far back as the 1970s, it was already well known that thyroid hormone was protective against heart attacks?
His name is Dr. Broda Barnes. He's written several books. We only have one, unfortunately, to show you. It's Hypothyroidism, the Unsuspected Illness.
Now, this is something that the late Dr. Ray Peat has discussed in many of his interviews.
Broda Barnes, who was a pioneer in the prevention of heart disease, and in his long practice of 30 years or so, he didn't have any one of his patients die from heart disease.
You've treated many people for heart disease using thyroid?
Yes, in the prevention of heart disease, because this is the only approach we have at the present time whereby we can prevent the hardening of the arteries that leads to heart disease. This thing is now 100 years old.
So if you are currently dealing with cardiovascular disease or have an increased cardiovascular risk, it may be worthwhile to take a look at your thyroid function. In fact, with the hundreds of clients I've worked with, I've seen correcting underlying thyroid dysfunction make significant improvements in their cardiovascular risk factors like elevated cholesterol, insulin resistance, high blood pressure, etc. So in this video, I'm going to show you the research from the 1970s that Dr. Ray Peat referenced, showing the protective effects of thyroid hormone on cardiovascular disease. I'm going to go through some of the more recent research showing the mechanisms by which thyroid hormone protects against cardiovascular disease. And I'm going to show you the labs and metrics that you can look at to gauge your thyroid function, as well as share some basic strategies that you can incorporate to help improve your overall thyroid health. Now, before we get started, many of the core strategies I use to help my clients recover their thyroid function are dietary strategies. However, I can't cover all of the exact dietary strategies in one video. So I'll be making a separate video covering all the dietary strategies in detail. But in the meantime, I created a free pro-metabolic diet calculator and food guide that you can use to build a personalized diet to help support your thyroid function. The link's in the description. Okay, so I want to start off with some of my stories from working in the ICU in terms of cardiovascular disease, because I worked on a cardiac ICU unit for about a year while I was still working in the hospital. And I saw many people come in who had diagnosed hypothyroidism, but they still had symptoms of hypothyroidism and they were still having cardiovascular disease. Now, they were on therapy, they were treated with levothyroxine monotherapy, but when you look through their charts and when I'm looking at their blood pressure, I'm looking at their blood glucose, they still have high blood pressure. They still had elevated blood lipids, elevated cholesterol levels in their labs. They were still dealing with insulin resistance. Some of them were type 2 diabetics. Some of them were pre-diabetic. And then many of them were still having heart attacks. They were still having strokes. And they were also still having heart failure. So when I started to look at this research and I started to see what was going on when I was working in the ICU, there's a mismatch. Because when you look in the research, you see that dialing in thyroid function actually has very significant benefits on cardiovascular health. And there's quite a bit. We're actually going to talk about some very interesting research from a researcher named Dr. Broda Barnes, where basically it can actually help to protect heart attacks. So I guess the question is, why was this happening? Now, my theory is here, and we'll talk about this when we get into some of the thyroid stuff, is that the T4 monotherapy, the levothyroxine, wasn't effectively managing their thyroid function. It wasn't being converted downstream into T3. And that's actually a big component. And when you look at their subjective symptom profile, and even some of their objective symptoms like their body temperature, it wasn't dialed in. And the labs that we were looking at, it was just TSH and maybe a T4 value. So it was only gauging based on the TSH. We weren't looking at the free T3, the total T3 values, the reverse T3. So a lot of these people could have still had clinical hypothyroidism symptoms and their thyroid function wasn't dialed in, even though their TSH values were low. So important piece to talk about here, because when we talk about testing, we're going to talk about all the values we should look at and also dial in all the strategies. And you want to make sure thyroid is dialed in effectively, because it's going to be extremely important for managing your cardiovascular risk. So there's some quotes from one of Dr. Peat's papers titled Thyroid Therapies, Confusion, and Fraud. What Dr. Peat says in this paper is he says, Broda Barnes, more than 60 years ago, summed up the major effects of hypothyroidism on health very neatly when he pointed out that if hypothyroid people don't die young from infectious disease, such as tuberculosis, they die a little later from cancer or heart disease. Barnes experimented on rabbits, and he found that when their thyroid glands were removed, they developed atherosclerosis, just as hypothyroid people did. But by the mid-1930s, it was generally known that hypothyroidism causes the cholesterol levels in the blood to increase. Hypercholesterolemia was a diagnostic sign of hypothyroidism. Administering a thyroid supplement blood cholesterol came down to normal exactly as the basal metabolic rate came up to normal. The biology of atherosclerotic heart disease was basically solved before the Second World War. So basically what we're seeing is that a symptom of hypothyroidism was high cholesterol. And then basically people who are hypothyroid, if they didn't already succumb to some infectious disease prior, because thyroid is important for maintaining immune function and immunity, they would eventually develop chronic disease later, which we'd see in cancer and heart disease. And basically in Dr. Broda Barnes' work, he was showing that giving his patients thyroid or optimizing their thyroid hormone levels actually helped protect them from heart disease. So what I want to do now is I want to take a look at some of the research from Dr. Broda Barnes' book. His book is titled Hypothyroidism, the Unsuspected Illness. So there's a picture of the book here. And then I took a chart from his book and I just organized it. It's his numbers, not my numbers. It's his research directly from this book. And I just laid it out so it's a little bit easier to read. And basically, this is coming from Dr. Broda Barnes' patient population. These are patients that he had treated with thyroid medication. And then we're looking at their rate of coronary cases or heart attacks. And basically what we see is we have different groups here in these columns. So we have females aged 30 to 59. We have females who are at a high risk. They have high cholesterol, high blood pressure, or both. Then we have females over the age of 60. Then we have the same groups for men. So men aged 30 to 59, men who have high cholesterol, high blood pressure, or both, and then men over the age of 60. Then what we basically see is the number of patients he treated in each group. And then when we come over here, he puts an interesting column here. It's the expected coronary cases according to Framingham. So these are the number of coronary cases that we would have expected in these different groups based on these demographics, based on some of the Framingham data. And so as an example, when we're looking at females aged 30 to 59, when we would have expected them to have 7.6 heart attacks in that group based on the number of patients treated. But we see that in the female group aged 30 to 59, he treated 490 women. There should have been 7.6 heart attacks, but there was 0. We look at the next one, we see in the high risk group, the high cholesterol, high blood pressure in women, he treated 172 of these women. There should have been 7.3 cases. There was 0. What about females over 60? When we look at females over the age of 60, he had treated 182 women. There should have been 7.8 heart attacks. There was 0. When we look at men between age 30 and 59, he treated 382 of them. There should have been 12.8 heart attacks in this group. There was only 1. Then we look at men who have both high cholesterol and who have high blood pressure. He treated 186 of these men. There should have been 18.5 heart attacks. That's what would have been expected based on the Framingham data. But instead, there was only 2. And we come over here, we see men over the age of 60. He treated 157 of them. And then you would have expected 18 heart attacks in this group, but there was only 1. Altogether, if we take all the populations together, we take all these groups that Dr. Broda Barnes treated, you would expect there to have been 72 heart attacks. There was only 4. And so basically, this is showing us, at least based on Dr. Broda Barnes' work, that the patients that he treated to correct their thyroid dysfunction, there was a beneficial effect on cardiovascular outcomes where there was a decreased risk of heart attacks. And so obviously this is just looking at basic relationships to start. But the thing is in other research, we can see that the thyroid is actually protective against cardiovascular disease. So let's actually look at this. So we'll take a broad picture overview and then I'll go piece by piece. So what we see with thyroid hormone is when you don't have adequate levels of thyroid hormones, so here on the right side, we have low levels of thyroid hormone. You see increased atherosclerosis. You see increased inflammation and increased recruitment of the immune cells to the vasculature. You see increased blood pressure, and you see the endothelial function, the cells lining the interior of the artery, actually have a decreased function. They go into dysfunction. Now, when you have adequate thyroid hormone levels, then this is talking about in the brain. That's where they're talking about some of the astrocytes. But you see improved angiogenesis, so improved blood cell growth. You see improved function of the mitochondria in terms of their structure, their function, and also when mitochondria are working effectively, antioxidant systems are working effectively. You have decreased oxidative stress, and you have reduced apoptosis. At least this is in stroke situations, in areas where the brain is damaged by strokes. So the cells are actually preserved. So the thyroid function has multiple beneficial effects across the board, and this is well known inside the research. So what I want to do now is I want to go piece by piece and look at the different portions of cardiovascular disease where thyroid hormone or getting thyroid hormone dialed in can be extremely helpful. So the first one we have here is atherosclerosis. And from the research, what they say, this is from a paper titled Thyroid Dysfunction Atherosclerosis, a systematic review. They say thyroid dysfunction has been associated with cardiovascular disease, hypothyroidism, and subclinical hypothyroidism, which is characterized by elevated thyroid stimulating hormone levels and normal circulating free thyroid hormones, are independent risk factors for the pathogenesis of atherosclerosis and cardiovascular disease, affecting adversely endothelial function. And more specifically, they are correlated with high levels of low-density lipoprotein cholesterol, so your LDL-C, abnormal diastolic blood pressure, so altered blood pressure, and then low-grade inflammation, as well as hypercoagulability. So all of these components are key elements of cardiovascular disease, and thyroid is directly intertwined with them. The next thing we see is there's well-established connection between hypothyroidism and atherosclerosis. This has been demonstrated by several studies, as illustrated in particular by Pajotto et al., who have evaluated the association between subclinical hypothyroidism and CIMT in 8,623 subjects and found it positive. So CIMT is the carotid artery intimal medial thickness test, which is an ultrasound of the artery to see how much plaque formation is there. And they say even after adjusting for factors typically associated with an elevated intima medial thickness or a plaque formation in the carotid artery, such as cardiovascular factors. So they saw that even after they adjusted for cardiovascular risk factors like elevated lipids, blood pressure, etc., they still see that hypothyroidism, even subclinical hypothyroidism, is associated with cardiovascular disease. They say the median intima medial thickness was higher in subclinical hypothyroid subjects than in euthyroid subjects. So in people who had borderline thyroid function, they had a higher plaque formation in their carotid arteries than people with normal thyroid function. They go on to say Tan et al. Found that the CIMT, the carotid intimal medial thickness, the plaques in the carotid arteries, are higher in patients with subclinical and overt hypothyroidism than healthy controls, concluding that there's a positive correlation between CIMT and TSH. And this is actually something that I've seen in quite a few clients that I've worked with who had demonstrable hypothyroidism, and then they had gone and looked at some of their cardiovascular function. They've done CIMTs. They did see plaque formation, and then once we started to dial in their thyroid function, we saw their blood pressure come down, we saw their lipids come down, and then we'll follow up on their CIMT values to see if the CIMT, it takes some time, is able to actually decrease over time as well. So dialing in thyroid function is extremely important for minimizing the atherosclerotic plaque formation in the carotid arteries, which is a basically indicator of plaque formation elsewhere throughout the body, including the coronary arteries, in the aorta, etc. Now, the next thing is the thyroid hormones are extremely helpful for dialing in lipid metabolism, helping to shift your lipid panel. We say here, thyroid function significantly affects lipoprotein metabolism as well as some cardiovascular disease risk factors, thus influencing overall cardiovascular risk. Indeed, even with the normal range of thyroid stimulating hormone values, a linear increase in total cholesterol, low-density lipoprotein cholesterol and triglycerides, and a linear decrease in high-density lipoprotein cholesterol levels has been observed when increasing TSH. So essentially, as TSH increases, total cholesterol and LDL-C and triglycerides increase in HDL-C even in the normal range. So even if you're in the normally accepted reference range. They go on to say, although decreased thyroid function is accompanied by reduced activity of HMG-CoA reductase, that's the enzyme that produces cholesterol, total cholesterol and LDL-C levels are increased in patients with overt hypothyroidism. This is due to the decreased LDL receptors activity, resulting in a decreased catabolism of LDL and intermediate density lipoprotein, so IDL. Now, this is actually a problem. You can have an increased production, or you can have a decrease in a hypothyroidism. You have a decreased production of cholesterol at the liver through HMG-CoA reductase. But what happens is those lipoproteins float in the blood for quite a bit longer because the tissues aren't taking them up, because the LDL receptor that takes the cholesterol into the cells is actually lowered. Now, this is a problem because the longer those lipoproteins float around in the blood, the more likely they are to become oxidized, the more likely they are to become modified, and the more modified and oxidized they are, the more likely they are to deposit into the arterial wall and start to develop the atherosclerotic plaque formation. The last thing that these researchers say here is they say, moreover, A decrease in lipoprotein lipase activity is found in overt hypothyroidism, decreasing the clearance of triglyceride-rich lipoproteins. Therefore, overt hypothyroid patients may also present with elevated triglyceride levels associated with increased levels of VLDL and occasionally fasting chylomicronemia. So basically, they can have elevated triglycerides, elevated blood fats in general, because they're not able to actually pull the fats out of the blood and use them for a fuel source. So you're seeing in hypothyroidism, you're actually getting metabolic dysfunction where the cells are not taking up the fats and not taking up the cholesterol to use them as energy. So you're not flowing the fuel into the engine and converting it into energy. It's just sitting around in the pipes, and that's where you start to see significant problems. So we can see that hypothyroidism is directly involved with atherosclerosis, and it also has a negative impact on lipid metabolism. But the other thing that thyroid function can also impact negatively is endothelial function. So those cells lining the arteries. The researchers here say thyroid hormones are vital in controlling the synthesis of nitric oxide in the endothelium. Nitric oxide as a potent vasodilator is crucial in maintaining vascular tone and controlling blood flow. Studies have demonstrated that T3 increases the production and effectiveness of endothelial-derived nitric oxide synthase, the enzyme responsible for synthesizing nitric oxide at the vascular lining. This increase enhances the process of vasodilation and guarantees optimal endothelial function. So essentially, the cells lining the arteries are your endothelial cells, and they use nitric oxide, which there's a difference between nitric oxide at the endothelial layer versus in the mitochondria. There's a story for a different video. But essentially, what happens is they use nitric oxide to vasodilate. The thyroid hormone helps to maintain this process. So if you don't have adequate thyroid hormone, what winds up happening is that the endothelial nitric oxide production becomes impaired, and you can't vasodilate effectively, and this leads to impairments in blood flow. In contrast, thyroid dysfunction can disturb the equilibrium between signals that widen the blood vessels and signals that narrow the blood vessels. Hypothyroidism is linked to increased levels of endothelin-1, a substance that narrows blood vessels and decreases the availability of nitric oxide, leading to impaired functioning of the inner lining of blood vessels. The imbalance of these vasoactive chemicals leads to changes in blood vessel constriction and a decrease in the ability of the endothelium to widen blood vessels. Basically, when you have hypothyroidism, the blood vessels aren't able to relax, to dilate effectively, and you get an overproduction of a substance called endothelin-1. Now, endothelin-1 is not really great for the vasculature because it actually has damaging effects on the vasculature and can be damaging for the endothelial cells. So you have this impaired nitric oxide function at the endothelial layer and an increased amount of endothelin-1 when thyroid hormone isn't adequate, which drives endothelial dysfunction on top of the metabolic changes. So this is altogether, this is not great for vascular function on top of the shifts with the lipid panel. In line with this, if the arteries are not dilating effectively because of nitric oxide signaling, then you can see a negative impact on blood pressure with hypothyroidism, and that's exactly what they see. They say there's an increase in systemic vascular resistance and slowed ventricular diastolic relaxation and filling are present. The decreased metabolic rate leads to a decline in peripheral oxygen demand. Consequently, heart failure is a rare clinical manifestation of hypothyroidism. Elevated diastolic blood pressure, so that's the blood pressure on the bottom, is present in 30% of patients with overt hypothyroidism. Cardiac contractility and output decreases, leading to a narrow pulse pressure, so the numbers become closer together between the top and the bottom. And in hypothyroidism, renin release is decreased with an increased salt sensitivity. The consequent renal sodium reabsorption leads to expansion of blood volume by 5.5%. So essentially, hypothyroidism affects the blood pressure altogether, leading to an elevated diastolic blood pressure. The bottom number starts to pick up, and the increased pressure is not ideal for the arteries because it increases shear pressure on the arteries altogether. And then you have a change in blood flow to the tissues because of this change in metabolic rate as well. So another factor here, you have a shift in blood pressure, change in lipids, dysfunction in terms of the endothelial cell function, and also you can see an increased formation of atherosclerosis. So all these are involved or are contributing to this atherosclerosis. The last two pieces here to talk about is oxidative stress and inflammation. What the researchers say is excess TSH, which is thyroid stimulating hormone, is known to directly produce oxidative stress. Other studies confirmed the lipid peroxidation both in overt hypothyroidism and subclinical hypothyroidism as indicated by malonyl-dialdehyde, which is MDA, elevation. So this is a marker of lipid peroxidation. They say protein oxidation has been reported as well with elevation of protein carbonyls. In this study, the correlation now suggests that both the TSH increase and the MDA elevation could contribute to protein damage. So you get an increased lipid peroxidation and you get an increased protein modification, so damage to the protein structures in hypothyroidism due to the oxidative stress from the impaired metabolism as well as the TSH itself was problematic. The last one here for inflammation, they say Tade et al. Reported that hypothyroid patients had higher levels of inflammatory mediators, tumor necrosis factor alpha, interleukin-6, and C-reactive protein in healthy controls, and that levothyroxine treatment, so T4 therapy, which is the standard treatment, reduced but did not normalize these inflammatory mediators, these cytokines. Another study also found that levothyroxine treatment modulated the inflammatory profile of hypothyroid patients, decreasing their pro-inflammatory cytokines and increasing anti-inflammatory cytokines. So people with hypothyroidism have increased inflammation, and when you correct that hypothyroidism with medication, you actually see the inflammatory profile move more to an anti-inflammatory profile, and the inflammation actually decreases. Although with just T4 therapy alone, it doesn't bring it back up entirely to normal. There's still some elevated inflammatory mediators. So when you look at this all together, what we can see is that hypothyroidism, based on Dr. Broda Barnes' work, when his patients were treated with appropriate thyroid hormone, the number of heart attacks that he saw in his population decreased significantly compared to the normal population or expected results. And then following up in more recent research, we see that hypothyroidism or lack of adequate thyroid hormone can lead to atherosclerosis or is strongly associated with it, and can negatively impact lipid metabolism. It can negatively impact the endothelial function, the cells lining the arteries. It can increase diastolic blood pressure. It can drive oxidative stress as well as metabolic dysfunction, and it can also increase inflammation. Now, all of these are actually problematic because these are all directly involved in cardiovascular disease. So with all of this in mind, the question is, how do you test your thyroid function? And then how do you correct it if things aren't working effectively? So I'm going to do a whole video going through the testing in depth. But just so you know right now what tests to look at to get a sense of what's going on with your thyroid function, I'm going to give you a quick breakdown. So you want to gauge your symptoms. That's a really big, important piece that gets missed. You want to see, are you still dealing with cold hands, cold feet? Are you still dealing with constipation, with fatigue, insomnia, anxiety, some of these typical thyroid symptoms, loss of the outer third of the eyebrow, decreased reflexes in some of the tendons? So you want to look for all of these different components. Another big one is going to be your pulse and your temperature. So you want to look at your waking pulse and your waking temperature, as well as your pulse and your temperature about 30 to 45 minutes after your first meal. You can also check it in the afternoon, but those are the two big ones. Now, the pulse and temp is important because thyroid controls your basal metabolic rate, which controls your heat production, which dictates your body heat, your body temperature. So if your thyroid is low, body temperature tends to be low. The waking pulse, at least based on Dr. Broda Barnes' work, ideally should be 97.8 degrees Fahrenheit to 98.2 degrees Fahrenheit. After breakfast, you should see that waking temperature increase so that you're at least over the 98 degrees Fahrenheit. So that's after your meal. Now, the pulse is helpful because it gives you an idea of if you are running on stress hormones. If your pulse is exceptionally high, even though your temperatures are normal or in a good spot, it could be because of adrenaline or because of other stress hormones. Sometimes, though, the pulse can be low in circumstance, even if your temperature is good, and it doesn't necessarily mean hypothyroidism because there's multiple factors that actually can impact your pulse. So the pulse is not the most important piece. The temperatures are the most important piece. And the pulse is to give you context on what's going on with those temperatures. When you wake up, as soon as you wake up, you take your temperature. And then after about 30 to 45 minutes after your first meal, you're trying to see if the food is being metabolized to energy effectively and increasing body temp. And then how these factors change, which again, I can make a whole video on this, how these factors change can give you some insight into what's going on with your metabolic function. Now, outside of symptoms and outside of the pulse and the temp, there's some lab values that can be extremely helpful to understand what's going on with thyroid function. Now, these aren't perfect. They don't tell us everything. They don't tell us exactly what's going on in the tissue. That's why you want to look at pulse and temp plus symptoms plus the labs together so that you can kind of triangulate between all the pieces to get a full picture of what's going on. And I actually wouldn't discount any of those pieces when you're making your decision so that you can actually come to a reasonable decision with a good amount of information. Now, the labs that I like to look at are TSH, which is thyroid stimulating hormone. Then we have total T4, we have total T3, then we have free T4, we have free T3, then we have reverse T3. And then if you are concerned about autoimmunity, particularly something like a Hashimoto's, you're looking at the thyroid peroxidase antibodies or the thyroglobulin antibodies. We want to see all of these values. We want to see how they are working together to get a true understanding of what's going on with thyroid function, especially with pulse and temp information, as well as with the symptom profile. So if all these things look good, thyroid function is probably good. But if some of these areas are off, that can give you an idea that maybe thyroid function needs a little bit of help. Now, once you've seen what's going on with your thyroid function, right? Once you've kind of gauged with these different areas, the next things to consider are, what do I do to actually correct my thyroid dysfunction? And so there's a couple big players that I like to work through first with clients to make sure thyroid function is dialed in before you just go, right to thyroid replacement or thyroid hormone, whatever the deal is. The first thing is to get your foundation under control. This is extremely important. To start, the first step that I look to do is I look to make sure that calories are dialed in effectively. Too low calories can actually lead to thyroid dysfunction or lower thyroid signaling. Prolonged fasting can also lead to thyroid dysfunction, can downregulate thyroid function. The next one is protein intake. If your protein intake is too high, it can have a negative impact on your thyroid hormone. But if protein intake is too low, it can also have a negative impact on your thyroid hormone. Also, the protein to carbohydrate ratio can be important as well. If the protein intake is too high in relationship to carbohydrates, you can see a negative impact on thyroid function, even if protein intake isn't too high as well. And then you also have total caloric intake looking at that as well. So you want to make sure that these are dialed in. I like to shoot for about 0.64 to 0.82 grams per pound of protein per day. And depending on what your goals are, at least 150 grams of carbs per day, if not up to a 2-to-1 ratio of carbs to protein, so you can optimize thyroid function and keep some of the stress hormones low. With the calorie targets, I'd recommend checking out the free food guide and calorie calculator that I have to set up your pro-metabolic diet. So you can just go and calculate it right away because there's a formula there. The calculator is automatic. So you just plug in your numbers and it will spit out the values for you. The next one after protein is carbohydrate intake. We want to make sure that we have adequate carbohydrate intake so we have adequate insulin signaling so that our thyroid function is working effectively. So again, minimum is going to be 150 grams per day under most circumstances, and ideally at least a 2-to-1 ratio of carbs to protein, depending on your specific goals and context. There's some nuance in there. In terms of fat, I would actually look to make up the rest of your calories with the fat intake, somewhere between 20 to 30%. You're going to have to figure out what works best for you. I usually start around 25%, but these are some of the targets to first consider. Now, once the diet is dialed in, the next thing is to look at your micronutrient status. And this, I think, is heavily overlooked when people are trying to dial in thyroid function, because I don't think there's been a lot of talk around the idea that the vitamin and mineral status that you have controls what's going on with your thyroid hormone production and thyroid hormone signaling throughout the body. And I like to look at copper status, zinc status, iron status, selenium status, and manganese status. And I consider iodine status in here, although the iodine status is harder to test. Now, the reason these are important, we're going to go through them piece by piece here. For copper, copper directly supports thyroid hormone production, T4 production. It's important for the enzymes that are in the mitochondria, like cytochrome C oxidase, that are involved in energy production. It's also important in complex 4 in the mitochondria as well. And then copper is involved in the antioxidant enzyme function for superoxide dismutase. So if you don't have enough copper to make these mitochondrial proteins or to make the thyroid hormone, then you're not going to be able to correct your thyroid just eating more carbs or something like this. You need to have adequate copper status dialed in. And there's been a number of clients that I've worked with where their copper status, zinc status, iron status, etc., was suboptimal, and correcting that drastically improves some of their thyroid numbers, like their free T3 values, bringing the TSH down, etc. Now, next one is zinc. Zinc is directly involved in the production of thyroid hormones, and zinc also supports the deiodinase enzyme function, which the deiodinase enzymes take the inactive thyroid hormone T4 and convert it to the active thyroid hormone T3. So you want to have active zinc status so that conversion is working effectively. The next one is iron. And iron is, there's kind of you don't want to go too high, you don't want to go too low. The reason why you don't want to go too low is because the enzyme that makes thyroid hormone function is thyroid peroxidase, or TPO. And that is an iron-dependent enzyme. So if you don't have enough iron in your body, you will not be able to make adequate thyroid hormone. And also, iron deficiency can impact deiodinase enzymes, which help to take the inactive T4 and convert it to T3. However, if iron is too high, you can have a high amount of oxidative stress that could put pressure on the thyroid gland and some of the other tissues. So you also don't want to have a very high iron. Next one is selenium. Now, selenium, again, cofactor for those deiodinase enzymes, and then also directly involved in the glutathione antioxidant systems. Now, these antioxidant systems are quite important for multiple areas. Thyroid hormone helps to increase the production of energy metabolism, or the production of ATP at the cell. When the mitochondria are working effectively, you decrease ROS, but you also need to have adequate antioxidant enzymes there to help mop up any ROSs that's produced when you start to increase energy metabolism. So you want to make sure that your antioxidant enzymes are working effectively and your systems are dialed in. Selenium, iron, copper, zinc, these are important for these systems to work effectively. And then also in the thyroid gland, when the thyroid makes thyroid hormone through the TPO enzyme, it produces oxidative stress. And so you need to have adequate antioxidant defenses there to help protect the gland itself from excessive oxidative stress from that reaction. So having adequate glutathione enzyme systems present, which is dependent upon adequate selenium status, is extremely important. This is why you see things like selenium, or at least why I think you see things like selenium being helpful in situations where you have something like Hashimoto's, where you have autoimmune attack on the thyroid. Now, the next one is iodine status. Now, you don't want too much iodine because it can put pressure on the thyroid and it can increase oxidative stress in the thyroid and actually damage the thyroid. But you don't want too little iodine because the iodine is needed to make your thyroid hormones. T4 and T3 are essentially protein with iodine groups added to them. So T4 has 4 iodine groups and T3 has 3 iodine groups. You need to make sure you have adequate iodine so that you can make these hormones. And the last one is manganese. So manganese is a mineral that's important for the deiodinase enzymes to work effectively. And again, it's also involved in antioxidant defenses. So you really want to make sure your mineral status is dialed in effectively, as well as your protein, your calories, your protein, your carbs, and your fats. Then the next thing is to look at what's going on in the gut, because the gut microbiome can directly impact thyroid function. And as an example, some of the toxins produced by the bacteria in the gut, like endotoxin, can push your T4 away from being converted to T3 and move it towards reverse T3, which basically has an antithetical action to T3. The other thing is endotoxin can directly impair T4 production in the thyroid gland as well and adjust the whole thyroid axis from top to bottom in terms of signaling. So if you're having gut dysfunction, that can directly drive the issues with your thyroid functions. You want to make sure that you're minimizing gut dysfunction, bringing endotoxin levels down, as well as dialing in the diet and dialing in your micronutrient status. These are some of the core base strategies to incorporate to make sure the thyroid function is dialed in effectively. And also these will be cardioprotective in and of themselves as well. So there's a synergy here of getting all these components dialed in effectively. So now that you understand how pivotal thyroid function is for your heart health and how to support your thyroid, next you want to directly target your blood cholesterol levels to bring your cardiovascular risk down as low as possible. Watch this next video where I'll show you the exact supplements that I like to use with my clients so you can target your cholesterol without having to rely on statins.